Good afternoon, and Dr. Resler, thanks very much for having me here. And I do want to comment, that was an amazing presentation, Dr. Katavia. I had heard you before, but I also love the way that you are pushing that technology to accommodate to the needs of what the current situation demands. And what I'm going to be doing in my presentation is highlight some of the areas where there is an enormous opportunity to advance the outcomes by doing innovative work, such as what we have just heard present. So let me share my, my screen. Yeah, no, and the background, of course, that we are dealing with is how to use innovation and technologies to face some of the challenges. And the challenge for us in the substance use disorder world are quite complex and very urgent in a way, because of the inability to be able to decrease the number of people that are every year dying from overdoses. And those rates are going up. And the complexity of what is driving that overdose death, which is initially was prescription opioids, but that with time has basically become increasingly more related to synthetic opioids, and as well as drug mixtures of synthetic opioids like fentanyl and psychostimulants like cocaine and methamphetamine. So going from a clear epidemic on opioid overdoses driven predominantly from prescription opioids, this has data right now showing from 2019, where before the COVID pandemic, we were seeing that the numbers of deaths were still rising, driven by fentanyl, driven by stimulant drugs. And then the question is, what happens when we have COVID? And as you may imagine, this whole issue just exacerbated. And it exacerbated in two ways that I think are crucial for us to be aware of. And one of them was people with substance use disorder started, when you look at the data, recognize that they were more vulnerable to becoming infected. And this is data that just based on a large cohort of individuals from electronic health records at the inception of the pandemic, showing the increased risk overall for infection on individuals with substance use disorder, regardless of the type of infection: alcohol, cocaine, cannabis, opioid use disorder, tobacco use disorder. They all have significant increased risks of getting infected. And also, unfortunately, if they get infected, you also can see that in this group of individuals, the risk of death were much higher. So these are all COVID cases, and the rate of death at the beginning of the epidemic, of the pandemic, and the rate of death of individuals with COVID-19 who also have a substance use disorder, and you see significantly higher. And you also see the health disparities ultimately that have been exacerbated by COVID, where you can see a greater mortality among Black Americans, and this is further pretty dramatically exaggerated among individuals that are Black Americans with a substance use disorder. And as we ponder about what this data means, I mean, ultimately, what it is clear in terms of understanding why people are more likely to get infected, and why, if they get infected, more likely to die, there is a collision of two elements. One of them has to do with pharmacological effects of these drugs that influence physiological systems that make you more vulnerable for infection and for negative outcomes, such as pulmonary function, cardiovascular function, immune function, but also structural elements in our society that drive people that are actually have substance use disorder higher, a greater likelihood of being in environments where they can be easily infected, such as is the case of the high rates of incarceration. Subsequently, as the pandemic has advanced and we have been able to see, to vaccinate people, we have seen that actually the breakthrough infections from people that are fully vaccinated, and this is data for individuals fully vaccinated with messenger RNA vaccines, that driven, perhaps accelerated on the one hand by the Delta variant, but also by the decrease in the immunity elicited by these vaccines as time passes. The breakthrough infections, based again on a very large electronic health record, on people with no substance use disorder is 3.6, on people with a substance use disorder is 6.8. And interestingly, the highest breakthroughs were observed in individuals with cannabis use disorder. Again, what is driving this high risk of breakthrough infections? Absolutely higher likelihood of being exposed to environments where you are going to be exposed to people that are with the Delta variant, which is so highly infective, but also importantly, and again, a neglected area where actually tools like the ones that was just presented that enable us to monitor medical comorbidities, neglected has been the recognition that the use of substance use disorders actually, on the one hand, significantly increase the likelihood of chronic medical conditions, like we know that, of course, COPD, but we know also for cancer, but much less recognized is the contribution of chronic drug use to cerebrovascular pathology, to immune diseases, to metabolic diseases. And the frequency rate of these comorbid conditions is much, much higher than that in the rest of the population. But we are not monitoring it. So this is from the side of the COVID pandemic has made it evident that individuals with substance use disorders, one of the challenges where, again, technology could help us address is how do we manage and recognize the involvement of comorbid medical conditions that are making them more vulnerable, but also how do we use innovation to tackle some of these social structural issues that are putting them at greater risk. And then we have the other aspect about it. How did the COVID pandemic influence their drug taking? And again, I think that technology here can play an extraordinarily important role. Well, I was, again, at the beginning of the COVID pandemic, sort of perhaps magically thinking that with the close of the borders, it would be harder for people to get access to illicit drugs. And I was completely wrong. And this is data actually showing the number of seizures from various organizations across the United States from 2014 to 2020. 2020 is the COVID pandemic. For the number of seizures on cocaine, methamphetamine, heroin, and fentanyl. And just look at the massive increase in the seizures that come from the year before the pandemic and the pandemic. Methamphetamine dramatically increased, and fentanyl dramatically increased. These are two extraordinary potent drugs. In the meantime, we also seen an increase in cocaine, and on the other hand, heroin has become less available in the illicit market, of course, because these two drugs, cocaine and fentanyl, don't even require any type of agricultural needs or land to produce them. You can actually synthesize them relatively easily. So this is the way into the future, more and more use of synthetic drugs. And in terms of the challenges that we currently have is that we don't have accurate measurements, ways of measuring right away with sensitivity the availability of these drugs, whether it is on drugs that are being sold in the illicit market or on patients that are actually suffering from overdoses or being followed up in justice settings or in treatments. So there is a major need for better ways of monitoring the exposure of individuals to drugs, as well as the exposure of communities to drugs. And again, some of the examples that we see right now with COVID pandemic to monitor are become very relevant to this issue. What are the consequences of this increase in the availability of these very highly potent illicit drugs during 2020, as well as the other aspects of what happened with the stress and the closure of many community support systems that are necessary for people to be able to overcome strong urges to take drugs, but also harm reduction that actually protects them from overdosing. Many of those capabilities were closed during COVID. And so this is data that actually goes up to March 2021 and covers the 12 months of the pandemic up to 2021 and compares them in terms of mortality from overdoses of the 12 months that end up in March 2020, which is when the emergency declaration for COVID was made. And you see an increase from 75,000, 76,000 to 99,000 over 1 year period. This is by far the largest increase in absolute numbers that we've ever seen in terms of link with overdose deaths. That represents a 31% increase over an already very high rate of mortality. And if you look at the data itself, I mean, the way that this is coded, it doesn't represent, so for example, in the case of synthetic opioids, which is mainly fentanyl and its analogs, we have an increase of 54%, and we have an increase of 50% that reflects both basically predominantly methamphetamine. So, but many of these cases, at least 50% of these increases in cases of these 27,000 people that die were combinations with fentanyl. And also in the case of cocaine, these 20,000 people, 75% of them were combinations with fentanyl. So again, the reality that we're facing for is how do we address a polysubstance use epidemic? I mean, it is very rare right now to get in the illicit markets drugs that are being sold that are basically just one substance. And this has major challenges at multiple levels, and some of which can be, I think, helped by some of the technologies like the one that was just presented. There's been some innovation, I mean, policy innovations, I like to call it, policy innovations that have helped buffer some of the challenges that were implemented very, very, very rapidly at the initiation of the pandemic that allow, for example, dispensing of methadone, basically from having to go there on a daily basis to be able to take home methadone up to 1 month. And that has made it easier for patients. But also in buprenorphine, which is actually the most widely utilized medications for opioid use disorder, also changes that enable the clinicians to be able to prescribe buprenorphine through telehealth without having to see an individual. And that is the restrictions of the waiver requirements in order to be able to prescribe buprenorphine, as well as allow clinicians to be able to prescribe across states. That also made it much more accessible for many patients that otherwise would have suffered even more than what the challenges that we're facing. Extraordinarily important were also the changes that were made to facilitate the use of telehealth for the treatment of substance use disorders, that then open up the feasibility not just of following these individuals, but also addressing their comorbid medical and psychiatric conditions, as well as providing alternative platforms where they can actually sustain behavioral therapeutic interventions and group therapies that are so necessary for many of these patients to be able to cope with the challenges of drug taking. So we still have, of course, within the whole space of telehealth, and I think that's probably one of the most expanded opportunities brought up by COVID in general, and I think that there's still a lot of that obviously that can be done and can improve significantly. And among the improvements that I think are going to be required is those that are dealing with the treatment of people with substance use disorders. Because while many of these applications that many of them based now on using cell-based technologies are that while they are pretty good at initial interventions, they are much more challenging when you aim to retain patients in treatment. And what we're facing right now is not just that medications for opioid use disorder are pretty valuable, we know that, but they are actually the rate at which patients actually relapse and stop taking them is pretty high. It's close to 50% at 6 months. So again, the opportunity of using interventions that, for example, if you're monitoring someone in terms of their patterns of behavior, and you can use that to predict when they are going to be relapsing, you can do then an intervention to try to prevent it. So again, there's a lot of work that can go in that space. Also, we have to face that has become more challenging to right now use some of the medications that we have to treat fentanyl addiction, and that's buprenorphine, methadone, naltrexone. There is evidence that they work, but initiating patients on these medications is much harder, and the rate of relapse is also greater. And those the need for coming up with models and combining interventions to improve outcomes is sorely needed. In parallel, the deaths from fentanyl you saw the numbers, they're actually driving the very, very steep increases despite access to naloxone. And I think that there are some of the challenges there in terms of naloxone acting to the brain very, very rapidly. So many times it is too late when the person that is going to administer the naloxone arrives. And as I was looking at the data that Dr. Katabi was saying, one of the things that we have been urging researchers into looking to develop models that can automatically monitor actually when a person may be getting into an overdose. And you just saw the elegant data, how you can see the respiratory rate can be used to predict when there may be deterioration for COVID. Well, it's very likely that something very similar can be utilized for predicting when someone is going into an overdose. And the beauty about it is that you don't need to wait, until someone is going into an overdose in order to deliver naloxone. And in those circumstances, you may not need to deliver as high a dose of naloxone, which is the worry that a lot of providers have, because you don't want to trigger an acute withdrawal that becomes very aversive. So we have the opportunity of using technologies just like the one presented to also monitor how to optimally deliver naloxone so that it is not so aversive for the patient and they become compliant with using it. An auto-injector, for example, that delivers naloxone at a certain rate based on feedback in terms of the breathing. And that's one of them is how fast do you administer the naloxone. And the other one, very important, is that people are dying with multiple drugs on board. So are there strategies that we can develop, for example, for stimulating respiration through nerve stimulation? That's one of the things that has been proposed for other areas of breathing arrest. So again, applying them to interventions in this case would be very beneficial. In terms of technologies, I think that I want to highlight, there's a lot of work going on in terms of developing monoclonal antibodies, developing vaccines, but it's also an area that in my brain is extraordinarily exciting, is that of neurostimulation. And I'm showing here neurostimulation with TMS. But there are multiple ways in which you can stimulate the brain, and there are also multiple ways in which you can stimulate the peripheral system. And as I was looking at the data again of the respiration and the agitation, and in terms of occurring how valuable these physiological peripheral measures are, because there is increasing evidence that the peripheral system may be driving some of the emotional responses of individuals. And we know that to a certain extent in psychiatry. But now with brain imaging, it is possible to actually monitor how, for example, breathing or slow heart rate variability may be influencing some of these functional networks. And to the extent that we have that information, we may be able to use some of these data gathering in order to do targeted interventions to help, for example, in a case of someone that may be suffering from anxiety, to decrease their breathing, to give them feedback in real time. And in terms of substance use disorder, it may also be very likely that we can monitor by using these peripheral measures, actually when someone is starting to get craving and the intensity of the drive goes up, and to then deliver an electrical stimulation, perhaps through a peripheral nerve, that could help them disrupt it. And again, we need to think this way because now we have tools that we didn't have in the past, and we have a much better knowledge about how these systems are operating so we can target them. In the meantime, we're working very, very hard with the FDA to try to get them to approve alternative endpoints, to approve certain devices or approve medications that are not just based on clean urine, because clean urine is just one part of the picture. And then there are so many other outcomes that would be valuable. And it just strikes me again, as I was listening, I was very inspired by the presentation, that we can use these monitoring devices to help us identify the outcomes that can then lead to predict better outcomes. So if we can then do an intervention that shows this outcome, it can be serve as an intermediate biomarker that the FDA may be willing to use to actually grant an indication. So again, I think that in this respect, we just have to just think out of the box. And so my husband yesterday was telling me, Nora, why don't you think out of the box of what we are going to do for dinner? And I said, because for cooking, I like to think inside the box. But for science, I think it is crucial that we don't think outside the box. And that opens up the whole space of what we are doing. And which I want to leave you with one question. I mean, we have accumulated evidence and evidence of things that work, but they are not being implemented. So what is it that we do to actually change that equation? And a lot of that relates on actually the accessibility and the feasibility of sustaining those treatments or prevention or therapeutic interventions. With virtual technologies, with wireless technologies, with wireless monitoring, in principle, we should be able to provide a much more extensive set of treatments and prevention interventions to people that can help them actually reach recovery, or that can prevent them from going into a substance use disorder. But my last slide is actually one that is, I want to even be more provocative, because I think that if we are not, this is right now we're in a moment where we can make a lot of change, which is one of the challenges that we have in substance use and addiction, has to do with discrimination, stigma. And so the issue is, and also social and economic components are driving many of these disparities. And so the issue is, how do we use these technologies to address some of these challenges? And I've thrown it out on my own staff, and I said, you know, I went to speak with people in Baltimore, and I was asking them, why are you not in treatment? And the number one issue that each one of them told me is, I don't have a place to sleep. So I cannot go to treatment because I have to go in and do the line on the shelter. Each one of them said, homelessness, house insecurity, lack of food, all of those issues are driving the pernicious behavioral cycle. And so I said, guys, think about what innovations can we use to try to address some of these issues. And so as you see, I value technology very much. I value, again, innovative thinking, and I value thinking outside the box, except when it comes to cooking. Well, thanks very much, guys.